All right, good evening, and thank you for joining us for Astro and RT Answers Ask a Radiation Oncologist event. This session, we are focusing on prostate cancer, and we have three terrific panelists with us with expertise in prostate cancer, practicing radiation oncologists that are active in Astro, and we'll introduce them in a moment. A couple things about our format. If you have a question, please submit those, as we are looking to have questions from our audience this evening specific to prostate cancer, and we'll be going through those throughout the evening. To introduce our panelists, first we'll introduce Dr. DeVille. He is an associate professor at Johns Hopkins at Sibley Memorial Hospital, did medical school at Brown University, and completed his residency at University of Pennsylvania. So thank you for joining us. Our second panelist is Dr. Dominique Rash, and she is an assistant professor at UC San Diego Department of Medicine and Applied Sciences. She completed medical school at George Washington University School of Medicine and residency at UC Davis School of Medicine here in California. And our final panelist, Dan Spratt, is at the University of Michigan, where he's an associate professor. He's the clinical research chair for genitourinary research and the director of spine oncology program. He has leadership positions with NRG and also serves on the NCCN prostate guidelines panel. I did medical school at Vanderbilt University and residency at Memorial Sloan Kettering. Welcome to each of our panelists, and thank you so much for joining us this evening. My name is Ben Wilkinson. I'm a radiation oncologist that is involved in Astro's Communications Committee, and I'll be moderating this evening's presentation. So our format for tonight, we are going to be answering some prepared questions at first, just common questions about prostate cancer that we believe are typical of what we see in consultation and also come up at meetings. These questions are designed for patients and for loved ones, family members, so specific for someone who either recently has a diagnosis of prostate cancer or someone who is in the treatment process or in the follow-up process. We're going to try to address multiple areas. We are going to have the live questions coming in tonight from Facebook, and so please submit those, and we're going to be entertaining them throughout the evening. And then this reporting will be available online, so please share this with your friends and family as anyone that may have an interest in prostate cancer. So with that, let's start with our first question. Dr. Rash, tell us, what is a radiation oncologist? Many of the people that might be watching tonight may never have met a radiation oncologist. They may have met a surgeon or may know maybe a medical oncologist, but how is our specialty different? What do we do specifically to prostate cancer?
That's a great question, actually, because for a large part of my time in medical school, I didn't even know what a radiation oncologist was. So basically, I like to think of it as anytime somebody's been diagnosed with cancer, you're typically going to treat it one of three ways, either with surgery, some form of systemic therapy, which can be chemotherapy, or immunotherapy, which would be administered by a medical oncologist. And then there's radiation. And for radiation therapy, you typically have a radiation oncologist that will be your main doctor for radiation. And basically, radiation is the same type of radiation that you'd get for a CT scan or for an X-ray. But instead of just taking pictures with the radiation, we use a higher energy beam that allows us to cause damage to cancer cells. And so basically, we use radiation to preferentially kill off cancer cells while allowing normal healthy tissues to recover and heal from radiation injury. And it's a third way to attack cancer that doesn't involve knives, doesn't involve anesthesia like you would experience with surgery, and still offers local treatment or local control. So just like a surgeon goes in with a knife right at where the tumor may be or the lymph nodes nearby, with radiation, we can point the beam directly at the tumor and have local effects without it going everywhere like you might get with chemotherapy, which gets into the bloodstream and goes everywhere by its nature.
Yeah, that makes sense. For those who don't know, what does training look like for a radiation oncologist? How many years after medical school, and what do we focus on?
So as a radiation oncologist, you're in this unique position where you get to start studying cancer right off the bat after medical school. If you're a medical oncologist or if you're a surgical oncologist, you typically do 3 years or more of training in internal medicine or surgery before you start studying oncology. In radiation oncology, we go straight into studying cancer, and typically residency lasts for 5 years. You have 1 year of your intern year, which can either be in internal medicine or surgery, and then you do 4 years of radiation oncology specifically. A lot of people may even spend a year during that time just doing research alone. So radiation is known for being very evidence-based. We have a lot of data that kind of supports our treatment, and it's rare to find a radiation oncologist that would treat you just based on a hunch or based on a theory.
That's a good point for patients who are listening, is that asking for data or information during their consultation would be a good idea then, as we'd be able to speak to that. So that's great. I think it is important for patients to know that, or people listening, that, radiation is pretty common. At least 60% of cancer patients will receive radiation at some point during their diagnosis. And so even though they may hear of a medical oncologist, or a surgeon first, or they may meet another specialty first, it should probably not come as a surprise that they're going to meet a radiation oncologist at some point in the future. Our second question we have here, so how common is prostate cancer? Dr. DeVille, I know that you specialize in prostate cancer specifically, so you see it a lot, but in the general population, is this similar to pancreatic cancer or other types of cancers, or how common will the general population see it?
Got you. Yeah, so prostate cancer is very common. It's the most common kind of non-skin cancer in men. It's about almost 200,000 cases annually. The good news is that most men, as we'll probably be talking about for when they're diagnosed, it's generally picked up at a very early stage because most of it is done through screening. But it is, pretty common. I often mention to men, once they've been diagnosed with cancer, they'll say they learned so many other people that they knew, friends, family, that actually have been diagnosed with prostate cancer as well, and they might never have known. So about 1 in 8, 1 in 8 men is the actual incidence, and that's for non-Hispanic white men. For Black men, the incidence is actually higher. It's about 1 in 5 or 1 in 6. So it's even more common amongst African Americans.
And so an interesting thing that sometimes I hear is, prostate cancer is something that isn't that serious of a disease. Or maybe the phrase that you guys have heard as well is, you may die with prostate cancer, but not die of prostate cancer. Maybe speak to that for a moment, Dr. DeVille. Is this a cancer that can get serious or can be diagnosed at a serious stage?
Yeah, I mean, this is the fundamental challenge, I think, that we struggle with as oncologists, or even, primary care doctors that are screening, doing cancer screening. And when we pick up prostate cancer, I mentioned the majority of men, it's picked up in an early stage. So I think something like 90% will be diagnosed without metastasis. But there's a large percentage there that will be diagnosed with metastases. So when the cancer has spread distantly. And the survival for men, if you looked at a 5-year time point, can be fairly limited, then, anywhere from 25 to 30%. So, really, although we might hear that prostate cancer very often can be unaggressive or less aggressive relative to other cancers, there can be a prostate cancer that can, be ultimately lethal and can be aggressive. But again, the good news is that the majority of men who are picked up in earlier stages, they will have a variety of options available to them that may actually include no treatment at all, may include an observation or active, what we call active surveillance strategy. And so for prostate cancer, what we're doing once it's diagnosed is using a risk group stratification and placing patients into these categories of what we call low risk, intermediate risk, or high risk. And so then we'll devise a management or treatment strategy based on that. And so where you hear the expression that, all men will have prostate cancer by a certain age, or they sort of, they won't die of prostate cancer, they'll be living with it. Those are often referring to these very indolent or unaggressive prostate cancer, which we may classify as low risk, that can just be monitored and don't necessarily need to even be treated.
Dr. Spratt, one of the things that we hear, and there's definitely been some controversy around this about PSA screening. Dr. DeVille brought that up. What do you tell patients about PSA screening and how to, because there are some pitfalls and challenges with it. How do you address just general questions about should they get PSA screening? Is there ways to make that a safe and productive process?
PSA testing is something that has a tremendous amount of confusion that I think expert organizations, our U.S. Preventative Task Force and others, I think, has created a lot of confusion. And PSA testing, just for those listening, it's a simple blood test. It's just like you would get your blood drawn for any other laboratory test. So the test itself is not harmful. Okay, so that's just important. It's a very simple test. It's really what you do with the PSA information that is really of debate and concern. In 2012, the group that really tells us, at least in the United States, should we do screening for colon cancer, skin cancer, prostate cancer, essentially said probably there's not really much benefit and probably we should not be doing PSA screening. And appropriately, the primary care doctors listened to the guidance by the organizations and did not. But the main confusing point was that the studies that they used they had some major limitations to it. And so really what I say is that what they concluded was based upon, at the time in 2012, when a man had a rising PSA and was biopsied and was diagnosed with, as Dr. DeVille mentioned, a low-risk prostate cancer, it was fairly uncommon at that time to just watch those patients or do what we talk about active surveillance. Many of them at many centers would undergo radical therapy, which has its associated side effects. And so overall, when you weigh those potential side effects for a cancer that would not have harmed the man, the task force basically said, we're not sure if we should really be recommending screening. Fortunately, as more analyses and data were looked at from those trials, the task force really realized that there were some major limitations. So they revised that in the past few years with an updated recommendation to say, maybe consider it. It's not a strong, yes, you should do it, but it allows it for men between about 50 and 70. Each organization has somewhat changed the exact years for men. But I think now the PSA screening rate has gone up. And so as Dr. DeVille was mentioning, it used to be about 220,000 men were diagnosed per year. And that fell to like 160,000 because they weren't doing PSA testing. And now it's back up to, as he said, close to 200,000. And so I think it's the PSA test I strongly encourage men to get. I think it's very important what they do with that information and who they talk to about that information to really understand if they should be having a biopsy, if they should be doing any other testing, and to make sure they're fully informed about the risks.
So to that point, Dr. Rash, is there, if you have an elevated PSA, let's just say a patient, primary care, PSA is elevated, is that an indication to go directly to a biopsy?
No, I think especially if your primary care is getting the PSA tested for you, he or she will have a conversation with you about what else may be going on, if you've had any recent infections or any recent trauma in the area. But there can be multiple reasons why your PSA is elevated. I don't know if I should say this, but I had a friend in pathology once. In pathology, they're the ones that regulate all the laboratory work that's done. And they used to joke that the PSA was sometimes, they call it the PSA prostate non-specific antigen. So there can be multiple reasons why your PSA bumps up. If it's high enough and there's a high suspicion, let's say you have a family history or there's other reasons why your primary care doctor might be concerned, then yes, maybe getting a prostate biopsy right away is the right answer. But like I said, there can be other reasons for that elevated PSA. So it's worth discussing in detail with your doctor.
So possibly either repeating the PSA to make sure that it's elevated again. So if someone's listening to this and they have a PSA that might be elevated, there are reasons to take a breath in and maybe repeat that, talk about some kind of benign reasons and non-cancer reasons that PSA might be elevated. Dr. Spratt, let's say you have an elevated PSA, are there metrics that you use of how quickly the PSA is rising, or we hear about PSA density, percent free PSA, how detailed do you think patients get into that, or do you think that that's much more in trying to make treatment decisions?
I think all the points you mentioned are important to look at. The way I sort of view early detection, really, which is what we're talking about, is there's not necessarily, and it sounds odd, there's not necessarily a value in diagnosing a Gleason 6 cancer. We want to make sure we are diagnosing clinically significant cancers. So most people define that as Gleason 7 or higher. There's a lot of tests. Some of it includes MRI testing, which has quite a bit of robust evidence to do prior to a biopsy, which the main goal is to avoid diagnosing Gleason 6 prostate cancer. There's also some blood tests and some urine tests available that their main metric and benchmark is, do they diagnose clinically significant cancer? You can use, the PSA, the rise of PSA, ruling out, as Dr. Rash had said, if there's another cause infection, things such as free PSA. I think all of these, provide some information. Although it's not as something talked about as much, but the digital rectal exam now in the PSA era, it still though detects, in the single digits, some may say a little more than that, of prostate cancer, even when the PSA is low. So that's still a component that's important. And goes back to, we call it your pre-test probability, but really what's the likelihood? So the family history, as Dr. DeVille said, is it an African-American man where there might be a higher potential risk of developing prostate cancer? That may skew your threshold of wanting to do that biopsy. Always, we have to remember, as we'll talk about, if this is an 85-year-old man versus a 45-year-old man, is it worth potentially doing that biopsy in someone depending on what their life expectancy is? So I think all of these things that's why I think what you do with that PSA information is critical.
Yeah, that's, I think, excellent. And important for, some of the people that are listening or watching this to know that PSA can actually be low and still have significant disease that may be there. So really getting to the previous points that Dr. Spratt made about, PSA is not the only, it's how we use the information. And so even a subtle change, even if it's below kind of the threshold that we think about, 4, 5, or 6, of if you have a low PSA and it changes year over year, a significant amount, that it should be a prompting to talk with your doctors, about what may or may not be going on, especially in the setting of having family history. Dr. DeVille, Dr. Spratt brought up MRI and potentially using that before biopsy. What is a multiparametric MRI or an MP MRI, and how do you use that in your practice?
Yeah, definitely. Well, let me add, before I answer about the MRI, I just want to mention one thing as we've been talking about screening. Just an important piece that I often emphasize to patients is, this idea of the shared decision making. And so most of the guidelines around prostate cancer screening, advise that the patient the patient and the physician should be having a conversation around the risks and benefits of checking the PSA. So usually I tell most men, if you don't know if your PSA is being checked, then you are not being screened appropriately, because we see a lot, I'm sure that my colleagues can agree, we see a lot of folks that were diagnosed with prostate cancer when you ask, was your PSA being checked? And they'll say, I thought it was, I think so, I'm not quite sure. And so really, if we're screening men appropriately, we really are should be having that conversation. And so part of that then is also teasing out these risk factors that are, the guideline, as was stated before, it actually is for men who are average risk or sort of normal risk. But if you do have an African-American male, or you have a man that has a lot of first degree, male relatives, a father, brother, son, that has been diagnosed with prostate cancer, particularly at a younger age, under age 65, that those men really should be having their PSA checked. But actually what we saw happening when those guidelines were changed back in 2012 was a lot of men who did not fall into that normal or average risk were not actually being screened as they should have been. And so it sort of enhanced a lot of the disparities that we see with prostate cancer in terms of who is more kind of affected and ultimately has poor outcomes when their disease is not picked up early. So I think a key is just really emphasizing that conversation between the patient and the physician, have that conversation with your doctor. Because I think a lot of these other things we've been talking about will also come up in that conversation. You'll sort of be better prepared to know, okay, if it is elevated, what are then the next steps? Will I be doing a biopsy? Could it be related to something else? It will prompt some of that. And so along that line is this conversation around the MRI. And the MRI has developed, over time as an excellent, kind of resource to really help improve our diagnostic accuracy with prostate cancer. And really, what used to happen before we kind of had, so MRI, sorry, just to take a step back, is an imaging study. It's a magnetic resonance imaging. So it's just and many folks probably have had MRIs for, other things unrelated to cancer, but it's really good at looking at soft tissue kind of delineation. And so over time, they've developed techniques to image the prostate. And so multiparametric MRI, I think of it as kind of a zoomed in look at the prostate gland. And it does these different, we call them sequences, but there are different ways to just sort of manipulate the imaging to look at, how the tissue is visualized on that scan. And cancer has different characteristics from normal tissue. So you can start to pick out, are there areas of tumor within the prostate? And prostate cancer can be challenging to diagnose because while the PSA sends a signal, it doesn't tell you necessarily where that cancer is located. And prostate cancer can be multifocal within the prostate gland. You can have multiple areas. So the MRI can now assist ahead of the biopsy. It's being kind of increasingly incorporated. Once you can identify areas of tumor within the prostate, rather than doing a traditional sort of blind biopsy where the urologist goes and kind of systematically samples different sections, or we call them sextants of the prostate. And traditionally you had this sort of 12-core biopsy that was then passed on to that pathologist. Now with the MRI, they can still do that to make sure there's not cancerous in, cells in other places, but they can go after those dominant lesions, we call those dominant areas within the gland, and sample those a little bit better. And that's been shown over time, again, to improve the accuracy and help spare patients from kind of repeated, biopsies that maybe weren't really catching or detecting the cancer. And it's a pretty simple, non-invasive study. You kind of spend an hour in a sort of tube that sometimes folks might have a little bit of claustrophobia or sensitivity to, is probably the biggest barrier. Or if they have, sometimes metal might be incompatible, or a pacemaker or something like that. There may be some challenges to getting an MRI, but we're seeing it increasingly utilized ahead of time to help diagnose prostate cancer.
So Dr. Spratt, if someone had an elevated PSA, they repeated it, it was still elevated, and they underwent maybe one of these more traditional biopsies, which we've all seen many patients that have done that, and they have a diagnosis of prostate cancer, do they need to go backwards and get an MRI, or potentially do one of those more specific biopsies at that point? Or are there cases where maybe you would feel comfortable still discussing treatment options at that stage?
Yeah, so I would say that, as I think Dr. DeVille said it well, the MRI in some countries, it is the standard of care prior to doing a biopsy. In the United States, we're getting there, but actually we're still not, I would say, as a national standard. So I would say the most common biopsy in the United States is the systematic ultrasound guided biopsy. The benefit of getting an MRI after a biopsy, after confirmed prostate cancer, I think it really depends what the clinical scenario is, right? There definitely can be benefits to obtaining an MRI to help guide various subsequent treatment decisions, but it really goes back to what's the goal with this patient. And so I think the biopsy information is only one of multiple components to really look at for a patient.
And so I think patients would be surprised to learn that it's possible for a traditional biopsy to miss prostate cancer. And I know everyone on the panel has seen that before, where a PSA will be elevated maybe multiple times and actually go up over time, which of course can sometimes not be cancer. But in retrospect, that the cancer might be just out of range of that biopsy, just in the approach of how the biopsy is done. Dr. DeVille, speak to that. What might be a warning sign that someone should kind of step back and really investigate the cancer might be there if that initial biopsy or sometimes even second biopsy is negative?
Yeah, I think, and to be, sort of frank or blunt about it, sometimes we see a lot of warning signs, but then we have a negative biopsy and folks are sort of happy, or they're sort of wanting to really believe that means there's not cancer there. But there can be a lot of warning signs that we really should not ignore and should pay attention to, again, because when our outcomes are always better when we can detect that cancer early. So one of the important things I think is looking at the PSA is not just the absolute number, but looking at the PSA trend over time. That's what I always tell patients matter, is your PSA trend over time, and not necessarily just sort of one point in time, although if it's very high, that's, then it sort of is what it is. But occasionally you can look back, at a man's trend, if they were having their PSA checked annually or every 2 years, and you can see that it was steadily creeping up, or they may have had large jumps. So we can look at things like the doubling time, or did it take a big increase like 2 points in 1 year? Are there other suspicious things? Or, as was mentioned by Dr. Spratt, that digital rectal exam, feeling something abnormal, sort of using all of our tools and resources to get a sense of like, are we very suspicious that there actually is prostate cancer within the gland? And so that's where, now we can try to utilize the MRI in that scenario as well. So very often you might see someone who was being followed and their PSA was sort of gradually rising. They may have had, sort of these negative biopsies that really weren't just detecting the cancer. And that might be the scenario where now that an MRI has been incorporated and might be able to detect that. But even then, there's something, depending on the series that you look at, there's some that, 10% or even more of these MRI series where cancer was not detected. The patient subsequently had a biopsy or had surgery, and we know that there was prostate cancer. So no tool that we have might be 100% accurate all of the time in detecting the cancer. So we do have to keep that. And I think it's important, again, to have that conversation with the patient, to express those concerns when we are very suspicious that there might be something going on.
Yeah, I had a terrific interventional radiologist that I worked with while I was in Tennessee, and he described it sometimes as being the front porch, to kind of put it on in terms of thinking about where this could be if you had like an anterior lesion. But there are times that you just were outside of the range, and so to all those points. And
just to add, that's actually that was shown by my colleagues at Hopkins, several years ago. Dr. Schaefer, who's now in Chicago, I believe, but for the urologists, and they looked at their series, their active men that had been on active surveillance, the African Americans were more likely to be upgraded at the time of surgery, and they found that they had this sort of higher predominance of anterior-based lesions in the prostate cancer in the prostate. And so the thought is those just really were not being accessed adequately for the traditional biopsy. So there are, and we haven't mentioned that, I guess, there are other ways to sample the prostate. And so historically, definitely prior to the, MRI era, we saw this, I think, a lot more, and there's a kind of resurgence of it. But, well, two things. You can have a saturation biopsy where rather than 12 cores, they're taking a lot more cores. You're seeing 24 or 28, you're seeing a lot more cores taken. Or you'll have a perineal approach. So the biopsy, rather than going through the rectum and using an ultrasound probe, they're actually going through the perineum, which is sort of the skin. I say, like, if you sit on a saddle, that's kind of the space we call the perineum, and your prostate sort of sits right behind that. And so the urologist can direct needles, and that can be a way to access more of that anterior portion of the gland that might not be easily reached through the traditional transrectal biopsy.
So we have a question from Facebook from one of our listeners. So they, specific to the types of biopsy, the question is, do they still use fusion biopsies of maybe the difference between fusing the image versus maybe what we might call an Endmore MRI biopsy. So Dr. Spratt, maybe explain that just a little bit about how those are similar or maybe different, and commenting on Dr. DeVille's point that you can sometimes still biopsy the whole gland in some of these MRI guided biopsies.
Yeah, so just to kind of be clear, probably the most common type of biopsy is based on just an ultrasound image, and that could be transperineal or transrectal. Many are moving, like at our center, pretty much to solely transperineal due to infection risks. When you have an MRI, one option is you take that MRI, it can be essentially processed and overlaid onto with technology onto that ultrasound image to help guide how you would approach that, to do a fusion biopsy to what they call an ROI, a region of interest, to specifically target that area. Many studies have shown that it's probably, you need to sample the entire gland in addition to that area as well. And there probably even are some, which I would say is the least common, but I'd be happy to hear from my colleagues if they do differently at their center. There are probably people under more live imaging techniques, but you would need all MRI compatible safe equipment to do a live image, to guide rather than the ultrasound your biopsy. I think that I've heard of, but I think that's exceptionally rare. Typically, it's a fusion technique. EuroNav is a common platform to be used.
Mm-hmm. Yeah, so I definitely, while in Tennessee, saw the Endmore process, and I would agree that is exceedingly rare, requires immense expertise. I think that maybe as time progresses, we're going to see improvements in MR technology and comfort level with that. But there's definitely data to go to what Dr. DeVille said of, prostate cancer in general can be multifocal, and you want to be careful not to, miss disease that might otherwise be out there. Dr. Rash, so let's say that someone has obtained their biopsy, they have cancer, and they're asking where to go for information. I'll make a plug for RT Answers through Astro, because we work really hard on that website. But beyond that, where else would you guide someone? What types of sites? Are there specific resources? And then I definitely want our other panelists to chime in on this, because I think that everyone probably has different resources that they like.
Yeah, absolutely. I mean, there's just like a wealth of information on the internet, and you can run down the rabbit hole very quickly, very easily. But generally speaking, I tell my patients they can always trust information that they're going to get from the American Cancer Society or cancer.gov website. And then actually, a lot of the guidelines that we use in practice come from the National Comprehensive Cancer Center Network, or NCCN, and they actually provide patient-specific information on the different disease sites. So if you want to get a general sense of whether your institution and your physician are following guidelines that are typically recognized across the country, that's kind of a reliable tool. And I basically tell my patients, if you're looking at a website that ends in .gov, .org, or .edu, you're probably going to be finding information that's safe and reliable.
And we have a couple of the resources. This comes from the NCCN patient guide, which can be downloaded from the website Dr. Rash mentioned. And I apologize, we've cut off some, but these are a couple of them. But Dr. Spratt, what do you tell patients? Are there specific books or guides, or how do you guide your patients?
So I tell them the internet is great, but it's also something that's very dangerous. I also say, cancer is like, patients who are diagnosed with cancer are extremely vulnerable and extremely susceptible to misinformation. They want the magic bullet, the wave of a wand. And I joke with them that, if someone said, Dan, eat a watermelon, all of it, the shell, and just shove it down, it'll cure your cancer, I would do it in a heartbeat. I do it every day if it would cure my cancer, to avoid, radiation or surgery. And people prey on that, on our patients, unfortunately. But I think the one that my patients have resonated probably most with is from the Prostate Cancer Foundation. If you go to their website, there's a link. They update it every year, actually multiple times a year. It's very comprehensive. And so I think it provides a balanced point of view, because there's a lot of information and books written by a radiation oncologist telling, there's the prostate snatchers, about, how bad surgery is bad. There's many books written by surgeons about how terrible radiation is. And I think this is one of probably many resources that really just provides the evidence. It's edited by a professional patient editor. So I think, they can understand it, because some of this information, can get very technical, or some of it's not detailed enough. So that's one of my favorite, but I have not checked out all the websites, which I'll do after this, for patients.
Dr. DeVille, what are your favorite resources and how do you guide patients?
Yeah, no, I think, these are the exact 3 websites that I've all have on my list as the highest recommendation, and that was not, pre-planned or anything, but it's the NCCN, it's PCF, and then it's RT Answers. So I think NCCN, I can't emphasize enough, because folks they're looking, they're reading, they're seeing so much stuff, they're overwhelmed, and you're sort of lost in like, what are all these options? And they say, oh, this person told me this, and this other person told me this. Well, let's go to the source of what are the actual national guidelines, what is appropriate, what is evidence-based, and it goes from A to Z, from diagnosis, workup, staging, management options, treatment options, follow-ups. It takes you through that whole course, and it's translated for lay folks. There's the clinician guide and there's the patient guide. So, before we would have back in the day kind of the pamphlets in the office or something. Now you just download it online, but before you could just give it to them. But really, you can get it all free online, and I can't emphasize that enough. As and family members as well, because family members confused about, what the options, and they want to provide support. And sometimes things start to sort of be less helpful and more confusing. PCF has great stuff, especially for diet and wellness, people that are interested in that kind of thing. And, foods, what are the diets associated with low rates of prostate cancer, that sort of information. And I think RT Answers has done a great job at radiation specific for folks who are, particularly for folks who are very interested in radiation and want a sense of what does it look like? What's the process? What's that simulation? How do we plan the treatment, the mapping? What's the machine look like? What's the room look like? What to expect for side effects in a very sort of easy, kind of reassuring manner almost. So those are my 3 go-tos as well.
We have updated the video, and if it's not live yet, it will be very shortly. So the patient experience video, we filmed some additional footage in DC area actually, and so we're looking forward to having that live of, again, showing that simulation process. So I appreciate you saying that. Dr. Spratt, one thing that you mentioned to me in the past was the importance of a multidisciplinary evaluation, which I think sometimes may or may not happen depending on, how a certain clinic is set up. But speak to that. Who should a patient see ideally when they're diagnosed with prostate cancer, once they get that biopsy result back?
Yeah, so typically in the United States, at least, urologists perform the prostate biopsy. There are some centers where actually radiology does, but in general, it's a urologist. And so depending on the center, the patient may have already had a conversation and went over the pathology review and had a talk with a urologist. I think that times are changing. I think that in a perfect world, which we are not in, patients would always be seen by a urologist, ideally a uro-oncologist, someone that is focused in prostate cancer, which the vast minority of urologists actually have any specialization in oncology, as well as at minimum a radiation oncologist. And for some patients, probably also a medical oncologist. And the real reason we have a multidisciplinary clinic, we're very fortunate at the University of Michigan, and we're trying to expand it. But cancer is, and it's important for patients to hear this, cancer and medicine makes money and there's a business component to it. And it's not to say that radiation oncologists or urologists ever are bad people, but there is a financial incentive in the United States for care to not be done in a multidisciplinary setting. For if you see person, let's say it's the urologist, to just say, I can treat you next week. There's no malintent usually. It's just extra work and extra logistics to have the patient see the radiation oncologist. And in the community setting, it may not be as easy. So it's, but the reason is that most studies, and I think most experts would agree, that the cure rates between surgery and radiation are very comparable. They're very different procedures. Going back to shared decision making, there's different side effects, there's different priorities, preferences, other treatments, other logistics. And so I think patients, to be fully informed about what their options are, knowing that each of us have a different expertise and a different vantage point, I think is very, very important. Because I think a lot of patients, given the way the workflow is in the United States, they only hear often, the majority of patients in the United States do not see a radiation oncologist, and they hear one option. Or if they hear about radiation, it's not necessarily the most up-to-date, modern, contemporary way that Dr. Rash or Dr. DeVille would talk about prostate cancer and what radiation therapy is. And so I would never pretend that I'm an expert with doing surgery. I know the bare minimum to kind of, but I should not be the one to, have an in-depth consultation on the pros and cons of surgery. And a surgeon really should be the one doing that, and vice versa.
So maybe for a patient who does not have immediate access to, a very large cancer center, a way to create that multidisciplinary approach locally, and not to say you can't travel for a consult, because a lot of patients do that, and maybe especially in COVID times of being able to do a telemedicine. So that's a great benefit maybe of this period of time right now. But a way to supplement a urology consult might be to, ask for a radiation oncology consultation at that diagnosis, to be able to have, maybe both perspectives. I will say that participating in multidisciplinary clinics, I always liked the medical oncologist being present, because they were kind of the referee, and being able to kind of say, what I hear you saying is that you can, treat it this way, and you both ways. And so we would come up with maybe a joint statement at the end.
Can I just add, the other thing is also, as we are, our treatments are becoming more and more multidisciplinary and sort of multimodality. And so even for, so we also have a multidisciplinary clinic, and we have expanded. We have it on our for Hopkins and on our main campus in East Baltimore. We also have it at Sibley in DC. I find it extremely beneficial, not just the patient, but as the physician, as the clinician, because, I think of it as this one-stop shop. You have all of the providers kind of in one space and time. And as they have to come to some consensus agreement. And so not only the patient and not just the urologic oncologist, as was mentioned, medical oncologist, radiation oncologist, but you have those diagnostic imaging experts, you have the radiologists, you have the pathologists talking about the subtleties of the Gleason score and why they may be, because we review all their slides, why they might have slightly changed one. Things that I would not get if I were just simply seeing the patient, by myself on my own. So it is so invaluable. And there is data showing that, patients then have better outcomes. You can potentially reduce ordering of imaging, unnecessary imaging and tests that, might have been ordered if you were sort of seeing them on their own and didn't have that direct conversation with the radiologist. So there's so many benefits to that multidisciplinary conversation. And nowadays, particularly as our imaging improved, we now pick up smaller areas of spread beyond the prostate. We start to think about, we have different systemic therapies or hormonal therapies, and, we're incorporating them differently in our treatment paradigms, as I'm sure we're probably going to talk about. So having the medical oncologist, kind of weigh in from that aspect becomes more important. At our center, we also do, as we may talk about, things like implant fiducial markers in the prostate and consider the space or hydrogel. And we have our urology colleagues do that, so we can have a real-time conversation. So there's so many added benefits to having, kind of all of the providers present and thinking about this as sort of the patient-centered approach, as opposed to the physician-centered approach where you sent them from office to office, and they were sort of left to kind of try to navigate through all these complex systems and put it all together. So it really can't plug that. And even if it's just as a second opinion, you know, prostate cancer, you do often have time to sort of think about, review all of your many options and come to a decision. So even if it's for a second opinion, we're happy to play that role.
Yeah. Dr. Rash, once someone has all their information, we're going to skip forward to question 12. Once you have all that information together, how do you stage prostate cancer? And specifically, you know, what is an overall stage or stage group? Because I feel like I will come across patients who they say, oh, mine's a T1C. And then that's the limit that they have, you know, of information. They haven't kind of gone past that of how else to stage. So how do you come up with an overall stage once we have the information we need?
Yeah, so for any disease site, we look at 3 broad categories to help us define the overall stage. So we look at the T stage, which is referring to the tumor, and typically varies based on the size of the tumor or what structures it's involved in. Then there's the N stage, which is referring to the lymph node status, whether or not the lymph nodes that drain the organ where the cancer is found are involved with cancer as well. And then finally, there's the M stage, which is referring to the possibility of disease that's spread elsewhere in the body. So metastases, that's what the M stands for. And then you take a look at that T, N, and M stage and come up with your overall stage grouping. And depending on whether we're talking about prostate cancer or lung cancer or what have you, how that all gets grouped together varies based on the prognosis of your cancer based on the T, N, and M stage. Now for prostate cancer in particular, it's a little unique in that we depend on these risk groupings, which Dr. DeVille had spoken about earlier to kind of guide our decision making. So prostate cancer, we have low risk group, intermediate risk group, and a high risk group. And then it's actually been further broken down into very low risk group, favorable intermediate, unfavorable intermediate, and then high and even very high. And it's constantly evolving, but the basic idea is that we take into account what you can feel, let's say on a digital rectal exam, or maybe what we know based on imaging in terms of where the tumor is located. And then we take a look at the Gleason score, which comes from your biopsies, which you've got highlighted very nicely on the screen for us. And then lastly, we look at the PSA and how elevated it is. And that's what we use to distinguish what risk group you fall into. And that risk group tells us what are the odds with the different types of therapy that will achieve what we call biochemical control, or rates, I guess, what are the odds that we can keep your PSA down and it doesn't come back or it doesn't rise again quickly.
So maybe important if someone doesn't have all that knowledge about their particular diagnosis to collect that and be able to, because that's going to guide treatment decisions, you know, to kind of say, well, are my lymph nodes involved or are they not, which is actually fairly rare, but important to know. Or, you know, how does my Gleason score, you know, fit in? What do those numbers mean? You know, what does the order of the numbers, does that matter, and understand that? We are closely approaching the end of our time. And so to Dr. DeVille's point, I want to make sure that we get to talk about some treatment details. Dr. Spratt, you know, something that I hear a lot is, isn't surgery more effective at treating prostate cancer? So why wouldn't you start with that first? And I have a slide from PROTECT trial, which I know you've mentioned to me before, next. So how do you go about discussing that?
So in general, right, we know what we know, we don't know what we don't know. I think in general, from well done quality studies, including a very well done randomized trial, I think it's very clear that outcomes are similar. Some people will say, are they identical? That gets a little, you know, into nuanced discussions, but I would say that in general, I tell patients, and so do our urologists in our multi-day group, we say for any stage of prostate cancer, talking about localized prostate cancer, low, intermediate, or high risk, that treatment outcomes are going to be equal long-term in terms of the chance of the cancer metastasizing to some other part or dying of prostate cancer, assuming you get the guideline recommended therapies. So as this trial you're showing here is a trial that compared surgery to radiation. They actually also got some hormone therapies to something called active monitoring, which is not really something done today. It was really just checking PSAs. We do more of what's called active surveillance today with typically PSAs, biopsies, and or MRIs and or some genomic tests. But even with just this PSA monitoring for men with about 75% were low risk and about 25% were intermediate risk. And actually there was a couple percent with high risk. But, and remember that these patients were low risk back then. And actually the grading system, probably a good proportion of these low risk patients may actually have what we call intermediate risk prostate cancer today. But regardless, you can't see a separation in any of those curves, meaning that men did not die more often, even with no immediate upfront treatment. And the curves on the right here are simply saying, you know, what's the freedom of the disease progressing? And obviously, if you don't do upfront treatment, it is more likely that disease will progress. But surgery and radiation, which are the red and blue curves, are identical. And so, at least in our practice, and this is a little different than probably national rates, but our use of radiation is substantially increasing compared to probably our rates of use of surgery. And that is, you know, radiation therapy now, we do a lot of what's called hypofractionation, in that it used to be 8 or 9 weeks of radiation therapy Monday through Friday, which is a very, in the state of Michigan, that is a logistical barrier when patients come from 4, 6, 8 hours away. Having an operation is very logistically attractive. Now that for many of these patients, we can do treatments, whether it's with brachytherapy and just 1 or 2 sessions, or with SBRT or ultra hypofractionation in 5 treatments. This is something that we are now doing substantially more radiation than we are doing surgery in this multi-D setting. So I think it's just important for patients. And that's why I also referenced that Prostate Cancer Foundation guide, which the NCCN doesn't really dive into. They make it very clear and explicit that for every risk group, the long-term chance that you will metastasize or die of cancer, there is no quality study that has shown one to be better than another treatment. And what I tell my patients is, trust me, if there was one that was better, it would be medical malpractice if we knew that to do the other, and we'd be sued up the wazoo, and you'd see ads everywhere. That data does not exist, and which is why. And I like to believe that doctors are good people. I don't think Dr. DeVille or Dr. Rash or you would be recommending a treatment option if it was inferior to patients that could have a superior option. So I think it's just good for them to know. But with that, it doesn't mean radiation's better. It means that they have similar oncologic outcomes, different side effects and logistics that should be discussed with the patient.
And to that point, you know, I know in my consultations on prostate cancer, I often talk about the advantages of surgery, you know, for patients to be thinking about it. And I've gotten stopped several times and say, well, wait a second, you're the radiation guy. Why are you advocating surgery? But Dr. DeVille, maybe comment on that. You know, what is it that, you know, that might be a patient you might say, I think you're better served with surgery. You know, who is it from a symptom perspective, or maybe finding out more pathologic information? You know, what is it that might, you know, warrant you to say, I think you might be better served with surgery?
Yeah, definitely. I mean, I think, so sometimes I'll just tell patients, you know, sometimes patients are sort of waiting to say, you're going to tell me this is the better option, or which is the better option. And so for prostate cancer, sometimes it's just not that simple. It's a little bit more complicated. And you may actually have sort of a menu of options. You know, our job is to really go through all of those options and then see, again, with this shared decision-making approach, which one may better suit you, you know, given your cancer characteristics, your overall health status, and just kind of your personal preferences, and sort of working through that. So it's not a quick conversation. You're really trying to go through all those details. There are some things that make it easy and obvious. So from a radiation perspective, you know, we do have some things that, you know, maybe we'll say they're not absolute contraindications, but that steer us away, or that might give us, you know, some caution. So things that have come up historically, like inflammatory bowel disease, or people who have, you know, active ulcerative colitis or Crohn's, that may get exacerbated by radiation. Well, if they have an alternative surgery and the surgeon says they're a good candidate, then that's probably steering us away from the radiation treatment. On the other hand, from a surgical perspective, the surgeon, wants to know that this man has a good overall health status and can tolerate the surgery. So, someone who has a lot of medical comorbidities and maybe a high anesthesia risk, or is maybe morbidly obese or presents sort of technical challenges to the surgery. Maybe they had a lot of abdominal or pelvic surgeries. There are things that might make it difficult for a surgeon to operate, and that patient may therefore be steered towards radiation. So sometimes there's some things that are obvious that way. Otherwise, in personal preferences, some men will say, I'm the kind that would just rather have a surgery and sort of feel like I'm done with this. I'm sort of one and done, although we know there's still a risk that cancer can come back. But nonetheless, they might feel better by just having surgery. Whereas other men will say, well, I never want to go to an operating room if I don't have to. And they say, well, let's go through, we have great radiation options for you, and let's go through this host of radiation options. So sometimes it's very obvious, and other times it may not be so obvious.
Good. I'm seeing from the Astro staff that we are running up on time. Any closing comments, from the panelists, important points? I've really enjoyed this discussion. I appreciate each one of you taking time to talk with us, but any parting thoughts that you want to share with the listeners?
I would say, this kind of just goes back to what we've discussed earlier about getting multiple opinions or seeking comprehensive care. Sometimes when you get a diagnosis of cancer, you kind of just want to get rid of it as soon as you can, get it out of your body. But with prostate cancer, generally speaking, you've got the time to kind of get a very well-educated decision made before your disease is going to substantially change. And so take the time to make sure you feel good about what you're doing.
Dr. DeVille?
No, I agree with that. We emphasized it before, but many folks, the hard, challenging part for prostate cancer often may be that they weren't referred to a radiation oncologist. So I'm glad, folks are listening into this. Perhaps they're, exploring or thinking about it. So would definitely encourage it, and getting multiple opinions, or even, just that second opinion, so that you can feel comfortable with the recommendations that are being made in terms of your treatment. So.
And Dr. Spratt, we didn't get to talk about genomics, but I want to give a plug for that because I love hearing your presentations about genomics from a medical perspective. So speaking to patients, maybe a 30-second plug of how to personalize their care a little bit through that, if they haven't done that already.
Yeah, I don't even know if I would want to use 30 seconds. That genomics is not the most important thing for them, but I will say that there's just a lot of amazing technology. There's a lot of research. There's a lot of clinically ready to use tests that I think can help us even further personalize treatments. I think, to just echo what the other panelists have said, is I think seeing a radiation oncologist or a multidisciplinary setting is very important. I think you should take the time to understand your disease, go through a shared decision-making process. If there's a doctor telling you that their treatment is best, I usually say a red flag should go up, that they're trying to sell you something. You are the one who should make this decision. They can give you information and see what's out there. There's a lot of information. We give resources. Some of that will be imaging. Some will be genomics about how to personalize therapies. And for men with aggressive disease, there's a lot of great clinical trials. And I think it's important for them to understand and ask about what clinical trials are available, because we can always improve outcomes.
Great. We'll end the series tonight on the RT Answers page. To find out more about prostate cancer specifically, you can go to select a cancer type there at the top, and prostate cancer, amongst other ones, are there. So thank you so much for everyone on the panel, and have a good evening, and thank you for joining us.
Yeah.